Good morning to everyone. I will be talking about the neurotrauma advocacy and role of neurotrauma societies because I believe that the rules and guidelines set by these esteemed societies will help to reduce the excessive burden of neurotrauma and help to strengthen the neuro rehabilitation program. Neuro program. First, I want to compliment Dr. Lynn Lucinia for her effort to start Neurotrauma Society of Philippines. In this effort, she hosted a first Philippine Neurotrauma boot camp last year, and I was also there physically. This boot camp was hosted with grand success. In this continuation of this effort, now she's hosting second Philippine Neurotrauma boot camp. And today there is also inauguration of Neurotrauma Society of Philippines. And I want to again compliment Dr. Lynn Luciana. I also want to compliment Board of Trustee, Dr. Manuel, Dr. Lina, Ibichi, and Giardo for their efforts. We know traumatic brain injury is a major cause of death and disability, and this is a global problem, which lead to great personal suffering of victim, relative, with huge direct indirect cost to society and nation. If we see the burden of trauma, it is day by day increasing because of rapid motorization, industrialization, migration, and changing values of the system. Most of the patient after trauma, they die because of the brain trauma, and 60% of death are because of the head injury. Trauma care in LMICs has improved in recent time, but far away from being a standard or protocol-driven approach, and process is relatively slow. After injury, there is instant death or poor quality of life among the survivors who warrant immediate remedy. In Apex Institution, an advanced trauma center, there seem to have a reduced mortality and morbidity because aggressive management of the practices, but it needs a lot of specialized manpower, diagnostic, and managerial skills. If we go to different countries of Asia, like Thailand, there is insufficient pre-hospital services which make difficult patient safely to go hospital. There is improvement in EMS is critical component of transportation infrastructure. We know that 90% of disabilities due to RTA are in developing countries. If we see the condition of Indonesia, which is a country of islands, their hospitals of varying standards are widespread, but have no system of emergency ambulance or patient retrieval. Now we come to our neighboring country, Pakistan, and other country, Latin America. Both are developing countries. In Latin America, there is increased insight of dispatch and increased training in form of PSTL course, which has improved pre-hospital care, while in Pakistan, they often do not have means of transportation for the patients. Nepal, which is our neighboring country, which has very difficult geographical condition, and there it is very difficult, and it is seen that 70% patients cannot go to roads, and they have to take help of human beings and back of the animals. On the other hand, Malaysia, which is also a developing country, but recent development and interest in emergency medicine training program has gradually lead to improvement in EMS and pre-hospital care. What are the major challenges? Major challenge in TBI, the death and disability. The victim and relative experience suffering and associate direct and indirect cost to societies are whose. Currently, up-to-date evidence-based TBI treatment guidelines do not exist. Proposed guidelines have been inadequate in approach, and the emerging technology such as biomarkers, DTI, and genomics has not been considered in older studies. If we see pattern of TBI, there is always polytrauma. In polytrauma, a medical condition involving multiple traumatic injury presents unique healthcare challenges. The complexity of these cases often necessitates a comprehensive multidisciplinary approach for effective management. For that, we need friends and family. For transportation, emergency medical technicians, first responders, which are very important part of pre-hospital care, medical coordinator, specialist, trauma surgeon, radiologist for diagnostic pillar. Without MRI, CTI, we can't do anything. Orthopedic and neurosurgeon, anesthesiologist and neurocritical, which is very important part of the care of TBI patients. Neurorehabilitation medicine specialist, which facilitating recovery. If we see the pattern of TBI, generally we see contusions, laceration, fractures. And spectrum of TBI is 60% mild, moderate 20%, 15-20% severe. It is same everywhere. Studies have shown that in Western countries, 1/4 patient has a multi-trauma, while in India and low developing countries or LMICs, we have 10% or less because mode of injury is different. So moderate to severe injuries, especially in situation of polytrauma, poses major challenges for management and recovery. See, physical examination is very important. We need multi-specialist, difficult airway, which is difficult to maintain. Exposure is important examination. If we miss this part back, patient would have died because of bleeding from the back. We need to check the abdomen, thorax, and the long bones. They are usually associated with the trauma. Trauma in special conditions like pregnancy. In pregnancy, we know at 20th week, there is enlarged uterus and fetus and amniotic fluid, which compresses the inferior vena cava. There is a decrease in venous return that decrease the cardiac output, cause hypotension. So to avoid this, we have to keep the patient in left lateral position, and we need to have a good resuscitation of the mother and good fetal monitoring. In pediatric trauma resuscitation, difference in head to body ratio and relative size and location of anatomical feature, children have more susceptibility of injury to the head and abdomen. Underdeveloped anatomy lead to chest pliability and less protection to thorax. These children has more cardiac arrest, so we need good resuscitation by using Breslow tape and ABCDE. Breslow tape is used by some institution during resuscitation. Rehabilitation, which is a very important, and it is in infancy in most of the LMICs. It requires interdisciplinary approach, and I want to suggest that all the neurotrauma center should have a neurorehabilitation department. This is neurorehabilitation department with our neurosurgery. Now I come to societies. National Neuroma Society's aim is to liaison with other organizations that influence the care and cure of neurotrauma victims, establishing standard in both basic and clinical research, excellence in field of providing opportunities for scientists, encouraging and supporting the research. The mission of collaboration of Neurotrauma societies is to enhance communication and provide a forum for efficient discussion, to enhance support on national and international level. And in collaboration, we need lot of subspecialties like policymaker, policy, ambulance, NGOs, first responder, they are very important in pre-hospital care, social media, intervention specialists, hospital care, and finally, rehabilitation. International Neurotrauma Society was constituted in 1995 with the aim to supervise international neurotrauma symposium throughout the world, host symposium meeting at different locations across the continent every 2 years, and INTS authorize the local host for each meeting and assist the local host organizing the committee through its international scientific advisory board. Up, Indian and global expert on traumatic brain, each other support for analyzing various ground realities. In this respect, we start the initial step toward the model emergency medicine system, and we've developed this national neurotrauma guidelines for our country. They are not evidence-based, but they are experience-based. Finally, they are very important to improve patient care. We also had a collaboration with the Neurotrauma US Society, and as a part of effort to enhance neurotrauma awareness and research globally, our Neurotrauma Society played a very important role to conceptualize Malaysian Neurotrauma Society. I want to compliment Professor Peter Lilly. He is also my mentor, who worked very hard as a chairman of Neurotrauma Committee for developing the pre-hospital care guidelines, hosting the lot of programs in collaboration with their national committees like Abu Dhabi, Myanmar, in my country, Pakistan, and in Shenzhen last year, before COVID. And last year we had this program in Philippines. We work also with World Federation and different continental societies like EMN, European Multidisciplinary Neurosurgical, for awareness, for hosting the clinical meetings and conferences and workshops. This is Neurotrauma Country effort at PGI Chandigarh in India. As I mentioned, national neurotrauma societies should work with the continental society for hosting this or various conferences. We also worked collaboration with China just before COVID, and it was grand success, meeting with grand success. And we faced the COVID, but we didn't stop. We continued our effort of hosting the meetings, having the webinars, virtual webinars, and research programs, and we involve a lot of persons from every part of the Asia, Australia, and also from different part of the world. And see, they were all our meetings and webinar during COVID period. In this series, our important meeting was in June 2021, where under guidance of Dr. Teasdale, we had grand success of this meeting, for which I want to thank Professor Teasdale for his support and blessing for this conference, where 82 countries participated, and cumulative audience was 25,800, and we telecast this meeting on Zoom, Universical TV, WeChat, and Zoom. So they are all big people, faculties all over the world which participated in this meeting. We extended our teaching program to other part of the Asia, Australasia, like Egypt. And I want to thank Dr. Nazar, Dr. Andrew Risner, Dr. Luis Borba, Dr. Tariq Khan for making their efforts for hosting webinars and different educative programs of TBI. Recently, we had a webinar under the leadership of Professor Yaku Kato and with grand success. And we had other neurotrauma meetings under ACNS banner. There is a scarcity of book on the topic of rehabilitation, and I want to just tell that AASNS also worked for publishing the rehabilitation in neurotrauma, this book. We also had a number of master classes during the COVID period. And again, I want to compliment Dr. Lain Luciana for her effort, active participation in Neurotrauma Bootcamp under agencies of AASNS. And in this, lot of countries were involved, and all the subspecialty of trauma section, cardiothoracic surgery, orthopedic, plastic, pediatric, gastro surgery was involved in the first boot camp, and it was hosted with grand success. Recently, we also had a World Federation meeting with AASNS, and here 56 international delegates with 428 total delegates, including the nursing, were there. And we had a workshop also, which was hosted first time in the world, where the microsurgery on the cadaver was shown on the ichthyoscope. So in conclusion, just I want to tell that most of the complex disease in our most of the complex organ is TBI. It is characterized by great heterogeneity in terms of etiology, mechanism, pathology, severity, and treatment with widely varying outcome. Finally, in conclusion, I want to compliment again Dr. Lynn Luciana for her effort in hosting second Philippine Neurotrauma Bootcamp and starting the National Neurotrauma Society of Philippines. And you must remember that we are always available for you. Any work for us, we will be there. And again, I want to compliment our best wishes for your future of this meeting. Thank you very much.